Without any further ado, our first case is the case of episodic and positional hypertension. And we've got two presenters, Mohammed Siddiqui and his mentor, Tanja Dudenbostel. Yes? Okay, please.
All right, it's been a pleasure to take part in this CPC again, and would like to thank the Hypertension Committee, Professor Anna Dominiczak and Professor Touyz, and the Hypertension Journal for giving us the opportunity to discuss this case. So it's a case of episodic and positional hypertension, diagnosis and treatment. So I'll be going over most of the case, and Dr. Dudenbostel would be involved in the discussion and the questions. We don't have any conflicts of interest. So we had a 59-year-old Caucasian man who worked as a carpenter, was seen in September 2014 at University of Alabama at Birmingham in hypertension outpatient clinic. He was referred for episodic hypertension, which was related to change in position. So he was having this episodic and positional hypertension since like 15 years. So when he was 45 years old, his episodic hypertension, the systolic blood pressure ranged from 140 to 275 millimeters of mercury, and the diastolic blood pressure fluctuated from 75 to 160 millimeters of mercury. The duration of episodes lasted for 45 to 60 minutes, and the episodes also occurred at night, mostly around 3 a.m. The patient attributed this episodic hypertension to chronic pain episodes he was having. The other symptoms he described was he was having nausea, vomiting, heart pounding, but his heart rate was normal. He had tingling sensation in head and spine and cramps in hands and feet. So these are the symptoms he was having while those 45 to 60 minute episodes where his blood pressure was going beyond 250 to 160. So the increase in blood pressure was when bending or turning to the right side. So it was episodic, but also was positional. So it was bending or turning on the right side. During night, he woke up and found that he was lying on the right side, and he was having those symptoms, and when he would check his blood pressure, it was super high. Other than high blood pressure, he was type 2 diabetes. He had type 2 diabetes, obstructive sleep apnea, dyslipidemia, gastroesophageal reflux disease, hiatal hernia, peripheral neuropathy, carpal tunnel syndrome, chronic pain syndrome. He had palpitations, anxiety, and memory loss. Most of his comorbidities were well managed. Type 2 diabetes mellitus was managed by metformin. His HbA1c was 7.1. Obstructive sleep apnea was treated on CPAP. Hyperlipidemia, it was controlled on diet and exercise. GERD was treated on proton pump inhibitors. He had surgically treated carpal tunnel syndrome, and chronic pain syndrome was managed by hydrocodone acetaminophen. He had earaches and ear drainage, noise and ringing in ears, palpitations on the first visit, irregular heartbeat. He had heartburn, indigestion, belching, and constipation. Genitourinary system, he was complaining of erectile dysfunction. Because of obstructive sleep apnea, he described he was snoring, has apnea and hypopnea episodes while asleep, and he had chronic pain, back and joint pains, muscular pains, leg cramps at night. He did complain of difficulty focusing on specific issues, He was a carpenter and also worked on making musical instruments. So he had problem recently while working on his carpentry. He had normal mood, denied any depression. On physical examination on the first visit, he was not in acute distress. He was alert and oriented. Neck veins was less than 5 centimeter, no jugular venous distension. Carotid pulses were bilateral without bruit. Neck was supple. Thyroid was normal in size and consistency. Lungs were clear, no crackles or wheezes, regular rate and rhythm, no murmurs, rubs, or gallops. Abdomen was soft. Bowel sounds were heard in 4 quadrants. No masses, no tenderness or bruise, no hepatosplenomegaly. On extremities, there was no cyanosis, no clubbing, no peripheral edema. Radial and pedal pulses were felt bilateral. Skin was warm and dry without any rash. There was no skin lesions. Neurologically, the patient was oriented to place and time. Strength and sensations were grossly intact. No focal deficits were found. Musculoskeletal examination showed he has tenderness, pain in his back, and pain in multiple joints. Vital signs on initial visit, his blood pressure taken on right arm was 180 over 110, in left arm was 176 over 110. The episodic hypertension episodes which he described was which range in 270s blood pressure, systolic blood pressure, but normal home blood pressure, when he was not having those episodes, his normal blood pressure was 140 to 150 systolic and 75 to 80 diastolic at home. He was alcoholic. He was former heavy drinker from age 17, but he had tapered down and was drinking around 1 to 2 times a week. He was a former smoker since age 17 until 2012, quit smoking 2 years back when he was first seen, and used nicotine patch to wean off. He was divorced, had 2 daughters. He did abuse a couple of illicit drugs. He used cocaine until 1986 for 4 to 5 years, and marijuana use was reported till 2014 when he was first seen. He was self-employed, worked as carpenter, furniture maker, and a musician. There was no history of any similar episodes in the family. Mother was hypertensive, had high cholesterol, and was diabetic. Father had no medical problems. Siblings, 3 of them had no medical problems, but daughter had asthma. When he was first seen, he was on the medication regime of doxazosine 2 milligrams twice daily, diltiazem 180 milligrams twice daily, nebivolol 1 milligram daily, metformin for diabetes, hydrocodone, acetaminophen for pain, baclofen, naproxen, acyclovir. Previously, he was treated with gabapentin and alprazolam. In summary, just briefly summarizing the introduction, it's a case of episodic hypertension related to change in position and pain. Blood pressure ranged during the episodes from 140 to 275 systolic and 75 to 160 diastolic. The increase in blood pressure was seen while bending or turning on the right side. Patient also reported nocturnal episodes of high blood pressure, which woke him up while he was lying on the right side. So we have a couple of questions. So just wanted to go over the differential diagnosis. So what would be the causes of increased blood pressure, which would relate to change in body position, and causes of episodic hypertension? If anybody could.
Okay, so we are waiting for people coming to microphones. Yes, we have almost ready for the microphone. I think, are we allowed what sort of tests we would want to do quickly?
Sure. Yeah.
Okay.
So I think it's very unusual to have this kind of blood pressure response to position change. And one of the things that can do that, and especially since the pressure has gone so high, is either something affecting the sympathetic nervous system with increased sympathetic discharge, or a tumor, such as a pheochromocytoma or paraganglioma, which, when changing position, may alter the secretory capacity of the tumor. So those are just a few things. I wanted to ask about BMI and weight pattern. Has there been any recent change?
Yes, we looked into it. There was, his BMI was 30, and there was no change in BMI from a couple of years. So.
Okay, and the total duration of the pain and these episodes?
It's 14 or 15 years.
14 or 15 years, so, and they haven't changed in character at all during that period?
Well, yeah. So actually, this patient did not have insurance. So when he got insurance, that was the first time he came to our clinic. So he was not treated, but he was having these episodes, but did not had any care to get these episodes seen by a physician.
And there were no episodes of hypotension accompanying this or associated with it at all?
No, we don't think he had any hypertension.
So one other cause of variability of blood pressure is abnormal baroreceptor reflex activity. But usually you get hypotension mixed in with hypertension with that. So this is straightforward postural or positional increase in pressure.
So that's great. We had differential diagnosis. I think now we'll get the tests, right?
So I just have a comment. I'm a doctor, but as my mom would say, not one that would do anybody any good. I have a PhD. Anyway, we've worked with patients at Serenity Lane Treatment Center for the Chemically Dependent and had people drink like up to a liter of sherry a day for several years. And this person had several years of primary dependent alcoholism, it looks like. And what we have seen is it kind of fries the baroreceptors. And there's a significant issue with supine to seated to standing measurements where there are wild variations because essentially the baroreceptors are fried. And I'm certain something else is going on, like pheochromocytoma or something else, but I just thought I'd make that point. Thank you.
Thank you.
Thank you very much.
Okay, we have one more.
Yes.
Can you give your name?
Oh, I'm Vivek Bhalla from Stanford University. The first question I have a comment about etiology. I'll save that for later. But I have questions about the timing of when this started. And I think it would inform the differential diagnosis. So this person was in 2000. He was 45 years old when this started. How sure are you that this actually started when he was 45, as opposed to somebody who had episodes from a young age that just simply were not detected due to a lack of medical care? You mentioned an adolescent that was a heavy smoker and heavy drinker for many, many years, and then when he's around 45 is when he stopped drinking, and he possibly was exposed to medical care at that point. So the first question has to do with, was there an inflection point? So when did this etiology of hypertension actually begin? Do you have blood pressures that were normal or a lack of episodes prior to the time that this began? That's the first question. And the second question is more of a pragmatic and simple one, which is that you mentioned a history of obstructive sleep apnea and that he was treated with CPAP, but you also mentioned symptoms that were consistent with not being very well treated for obstructive sleep apnea. And this is positional. So how well do you know that he's actually getting adequate treatment with the CPAP? Do you have a sleep study on his current fittings? Does the fittings change when he turns to his side? Questions really related to the efficacy of the treatment for that particular risk factor.
So to answer question one, so he reported that he was had first symptoms in 2000, and we had to believe that. And he reported that he back then had palpitations, and that was the main symptom basically that concerned him, and he was 45. And all the workup back then focused more on cardiac etiology. So he had a Holter monitor and I believe an echo or so, and everything came back negative. So he was told we cannot find anything, and since he didn't have insurance and didn't want to kind of follow up, he sort of was lost to follow up. And then in 2014, basically he came to our clinic in September of 2014, and he turned 60 in October. So he timed that on purpose because he knew he would then have insurance. And actually, we didn't manage that sort of because we wanted to get everything else done fairly quickly and enrolled him in our charity program so that we could do everything in September before he actually turned 60. And so that was the first question. The second question regarding the obstructive sleep apnea. So actually a friend of his supervises a sleep clinic and observed that he stopped breathing at night and said, I think you may have obstructive sleep apnea. So he actually had a sleep study done, got a CPAP machine, and when we asked about it, he said he actually felt like after he had the CPAP, it was better with the nightly episodes. He had less cramping and less attacks. So then for a while, he also felt like, maybe it's nothing so serious and I don't need to follow up on this because he felt like everything is getting better. And in retrospect, I feel like, maybe because he's more in a supine position with the CPAP machine and not turning as much around as you do without, that may have been one reason for the kind of benefits of the CPAP, just being more on the back overnight and for longer hours instead of turning left and right. But we don't have an in-between CPAP sleep study to see how many hours he actually used the CPAP and if it was still fitted after several years and the pressures were still okay and everything.
Okay, thank you.
Okay, we have one more, a few more.
Jan Basil from Charleston. Obviously, this is not a patient with just essential hypertension, and you have to think about secondary causes. I've wanted to say this a long time. I agree with Dr. Carey that I would be very concerned about a paraganglioma. He's got perspiration, pain, headache. He's got palpitations. Not that paroxysms are more common than not, but that's in there. And you just have to think about, he's not the average bear. The other thing is, although a 24-hour blood pressure is not going to lead to a diagnosis, I would like to know what his pressures are off his positional hypertension. Other tumors in that area would be very concerning to me. And he's very fortunate because you haven't told us labs yet. Renal function, proteinuria, LVH by EKG. What are the trophic effects of intermittent sympathetic output, overdrive? But so far he's very fortunate. As for the sleep apnea, it definitely has to be addressed. Repeat test after he gets a fitting and is he adequately controlled, but in no way do I think that's going to be an issue with his blood pressure. But as his general health, and to make sure the palpitations aren't from AFib with sleep apnea, etc., clearly needs to be done.
Okay.
Yeah.
We're getting warmer and warmer.
Yes.
Good.
Well, Brent Egan, Greenville, South Carolina, and I agree with what my colleagues have said, Dr. Carey and Dr. Basil. I just wanted to throw a couple of other considerations, potential considerations into the differential. Certainly the vertebrobasilar arteries, as they lie near the medulla in some very sensitive areas, can be sometimes positional and elicit a significant neurogenic hypertensive response. If this is an excess of catecholamines, it is interesting that you didn't see an increase of heart rate, which suggests to me that this is not predominantly an epinephrine phenomenon, but probably more of a norepinephrine phenomenon, that you're not seeing an increase in heart rate. You can actually see a reduction in heart rate with pure norepi tumors. So I think that's one potential concern. The other thing that will drive blood pressure crazy, and I'm not going to link this to position, but certainly renal artery stenosis can give you very episodic and fairly severe elevations of blood pressure. Doesn't have the heart failure symptoms that sometimes go with that, but I wouldn't entirely remove it from the differential. And then sometimes there's just autonomic instability that can be triggered by certain events. And I'm thinking, whether he might have a thoracic outlet syndrome or something that may be triggering this. So just to consider in the differential, I'd look for other things that could drive this other than just a catecholamine secreting tumor.
Thank you for these very good points.
George Roush from NYU, but you can only use my name if I'm right. So,
That's not how it works.
Well, we are all here to learn from each other,
okay.
So there's no right or wrong.
How much documentation do we actually have, apart from the office, of the magnitude of these blood pressure swings? Which I think gets to Dr. Basil's point about having 24-hour monitoring. Are these happening every night that he bends, or?
Sometimes he reported those nightly, but then sometimes just 3 times a year.
Oh.
So very inconsistent.
Very inconsistent. Okay.
And I'm not sure, we rely basically on a self-report by the patient, and then, like the audience just said, alcoholism may have played a role too. So in regards of reporting and accuracy and how the patient perceived it.
So that's certainly very interesting that a few times in a year.
Regarding the blood pressure, the 24-hour, we don't have an 24-hour blood pressure monitoring on him. And the blood pressures were self-reported.
So in a previous incarnation, I was a cancer epidemiologist, and alcohol and cigarette smoking interact dramatically to cause esophageal and other tumors. And I just wonder, could we think about some weird perineoplastic syndrome in this patient, whether that might...
Okay, we're keeping this in mind, and we go to the last comment in this series.
Boston, I wonder what is the nature of his chronic pain? What helps?
So he couldn't describe what exactly was the nature of his chronic pain. I mean, he was referred by us to pain clinic, and they tried several options, but maybe it was psychological, maybe it was chronic pain syndrome, but we did look into his chart and tried to find out the nature of his pain, but we couldn't.
It's a bit
kind of a chronic pain syndrome, and maybe related to osteoarthritis with the scrub.
Yes, but chronic pain syndrome is not really a clinic. It's not helpful in trying to understand what hurts. Was it in the hands, in the feet, in the abdomen, in the back? He was, I understand, someone who works physically.
Mm-hmm.
Yes.
So were the opiates helping him?
So yes, it was helping him. It was helping him. It was lowering, the pain and also the blood pressure. So that's what he attributed his pain to, was the position, and also said the hydrocodone was the only medication that was helping to lower his blood pressure.
Okay. I think we need to move on, because we will
never
get the diagnosis.
We will come back to the chronic back pain later.
Autonomic instability And
Okay.
episodic chronic repeated pain may hint of a weird form of porphyria, which is something
Okay.
that should be.
We will come back to
One
that.
more
Right.
comment.
Okay, last
This man
comment.
has a history of cocaine abuse.
Yeah,
We think he may have stopped it, but he might have continued it.
yeah.
And cocaine abuse is associated with abdominal pain, nausea, and hypertension in this range.
And tachycardias and palpitations and
All
all
of-
these
all of
things.
these things.
Right, so that is fantastic. We have a very, very broad differential diagnosis. We now need to do some tests.
Yeah, so here's just kind of some of the differential diagnosis for positional hypertension we considered. And we have to, of course, add all the really good suggestions we just heard, like dysautonomia, vascular adrenergic hypersensitivity, renal artery stenosis, aortitis, one of the more rare ones, and of course pheochromocytoma. And then the patient also had this kind of episodic hypertension, and there are other diseases to consider. So you could just have labile hypertension, and some men published extensively about that, mostly based on emotional stress. You could have an underlying pseudo-pheochromocytoma. You could have Page syndrome, which goes along with excessive dopamine secretion. The fear we discussed, but then his illicit drug use could play a role, and like Dr. Bushton just said, the chronic pain, back pain episodes could also play a role. So for trainees, why do we care about this blood pressure variability? We basically define short-term blood pressure variability and long-term blood pressure variability. So 24-hour blood pressure variability versus visit-to-visit or even seasonal, yearly blood pressure variability. And short-term blood pressure variability is associated with increased risk of left ventricular hypertrophy, an increased risk for target organ damage, strokes, and general cardiovascular events. And similarly, long-term blood pressure variability, there's also an association with stroke, coronary heart disease. In general, these patients have a poor cardiovascular prognosis and an increased mortality risk.
All right, so I'll go over the workup for the patient. So he was complaining of palpitations. So we did a Holter monitor, which was normal, did not show any arrhythmias or PACs, PVCs. Cardiac MRI was not done by us, but it was done by other physician, which was normal. We did echocardiography, which was normal. Stress test was negative. The laboratory workup, we did comprehensive metabolic panel, lipid profile, TSH, HbA1c, serum aldosterone, plasma renin activity. To check, we did plasma metanephrines, 24-hour urine for metanephrines and catecholamines for pheo. And for illicit drug use, we checked if it was abusing any drugs for urine, a urine drug detection screen. The comprehensive metabolic panel was normal, all electrolytes, kidney function, everything was normal. Cholesterol was slightly high, triglycerides were high. HbA1c was 7.1, TSH was normal. Urine drug detection, amphetamines, barbiturates, benzodiazepines, cocaine, methadone, opiates, all were negative. Aldosterone and plasma renin activity was normal. And then we did a 24-hour urine and a plasma for catecholamines and metanephrines. And this is what we found. Norepinephrine was high. Metanephrine plasma free was high. Epinephrine, norepinephrine, catecholamines, VMA, urine metanephrines, norepinephrines in 50,000. So normal reference values are less than, for total metanephrines are less than 1,300. He had 51,318. So we have not seen a case of this severe We have seen few cases, but not the severe levels of metanephrines and catecholamines. CT scan was done, chest, which showed no evidence of intrathoracic metastasis. An abdominal and pelvic CT scan was done. A large 8.4 centimeter heterogeneous mass with areas of central necrosis and calcification was seen, which was arising from right adrenal gland with possible extension into inferior aspect of right hepatic lobe. Findings were consistent with known pheochromocytoma with possible malignant transformation. So there was given presence of thrombus within the right adrenal vein. PET scan was done. It was a hypermetabolic right adrenal mass containing areas of necrosis, which corresponds with known pheochromocytoma. There was no additional suspicious lesions elsewhere in the body. So after putting on the medication, the patient described that doxazosine helped in reduction of his symptoms. Decrease in the dose of doxazosine caused the increase in severity of episodes. Beta blockers, he told, which was very typical precipitated episodes. But he again re-emphasized that his blood pressure was getting controlled by hydrocodone and acetaminophen. Based on clinical presentation, biochemical and imaging results, it was a 8.5 centimeter pheochromocytoma of right adrenal gland. Preoperatively, alpha blockade with doxazosine, 8 milligrams at night was given with titration in 2 milligrams increment according to orthostatic vitals. Beta blockade with metoprolol was done. Surgery was done in November 2014, right open adrenalectomy, a large mass in retroperitoneum. There was an extensive hypervascular tumor, significant number, blood pressure and heart rate fluctuations were seen throughout the surgery. During post-operative period in intensive care unit, the patient had NSTEMI and also had a slight atrial fibrillation during that period. Diagnosis, 8.5 centimeter pheochromocytoma, which was encapsulated mass. Serial sectioning of mass revealed a heterogeneous cut surface characterized by glistering, soft, solid, tan, pink tissue, and multiple large, smooth-lined cystic spaces filled with necrotic yellow debris. Prominent areas of hemorrhage were seen throughout the tumor. In microscopy, the cells were arranged in nests surrounded by delicate fibrous bands. Each nest was composed of cells with vesicular nuclei and abundant amphiphilic cytoplasm. A subpopulation of small hyperchromatic cells, which are denoted by arrow, known as sustentacular cells, were present at periphery of individual nest. Numerous capillaries filled with red cells were also seen. Post-operative medication regime, his blood pressure was better but not yet controlled. He was put on diltiazem, 180 milligrams twice daily, metoprolol, 50 milligrams twice daily. Again, the other medications were continued, metformin for diabetes, aspirin, baclofen, acyclovir, and hydrocodone, acetaminophen for his pain. Vitals before the surgery, we don't have the 24-hour blood pressure monitoring, but we got the blood pressure from his home blood pressure and the clinic blood pressure, which fluctuated. And after surgery, his blood pressure was not fluctuating. So if you can see the blood pressure fluctuation before the surgery and then after the surgery. In summary, it was a case of episodic hypertension related to change in position. Diagnosis was right adrenal pheochromocytoma by biochemistry and imaging. Procedure was done the right open adrenalectomy, which we thought cured his episodic and positional hypertension, but did not. So he failed to follow up, and he came back after a year with episodic variation of elevated blood pressure. But this time, he did not complain of positional episodic hypertension, but just blood pressure variation. Now his systolic blood pressure ranged from 120 to 170, fluctuated. Diastolic blood pressure fluctuated from 70 to 110 millimeters of mercury. The patient re-emphasized again that his blood pressure fluctuations were related to pain. So the first thing we did was get the 24-hour urine metanephrines and catecholamines again and see if there was any tumor that was not resected properly. So what we found was the levels were back to normal. The metanephrines, norepinephrines, plasma, the 24-hour urine metanephrines, catecholamines, epi, norepi, total metanephrines, everything came back to normal range. The other thing we did was to check for his illicit drug use, which was negative again. So this was his vitals. This was before surgery, which was fluctuating, and after surgery for a couple of months, his blood pressure was stabilized, and then again started fluctuating. So he was started on, so when he came back after a year, he stopped all his blood pressure medications, and he was not on any blood pressure medications. His blood pressure was high, and he was reporting a fluctuation. So we started again the diltiazem and then added chlorthalidone. He was followed in pain medicine clinic for his chronic pains. Patient was first getting treated by hydrocodone and acetaminophen, and they started him on tramadol this time for his pains. He was followed in hypertension and pain clinic for 2 years. Episodic positional hypertensive episodes were resolved, but not the episodic hypertensive episodes which came back. We were trying to figure out what could have been the thing with this episodic hypertensive episode, but we had unfortunate news that the patient, he died unexpectedly in 2017.
Okay, we have
So
some
in
more.
summary,
Don't summarize
okay.
yet. Let our discussants have their time of life. Yeah?
So that was a big, ugly tumor that was removed. And it had obviously grown very slowly and was at the root of the problem. And so even though the pathology did not identify a malignant pheochromocytoma, you cannot tell by looking at the slides whether the tissue is malignant or not. So one possibility here is that there was a malignant pheochromocytoma that had come back, either in the adrenal bed that was from the adrenal that was removed or at a more distant site, increasing catecholamine and metanephrines and repeating the process. The other thing that I hope was done, even though there was no family history of pheochromocytoma, paraganglioma, or any secondary hypertension, the patient really should have had a genetic analysis.
Yep.
The reason is not necessarily for the patient, but it's for the patient's immediate relatives. And once the abnormal genetic pattern is identified, then all direct relationships should be screened, and this should go on for generations, because the risk is often much higher than it is in sporadic pheochromocytoma.
Right, absolutely. And we discussed this just before the session, that genetic test is now an obligation, really. Maybe 17, 14, maybe not yet, but now absolutely it is necessary to do genetic tests because certain mutations have much more malignant change, and histology is completely unhelpful and hopeless in this differentiation. Please.
I would refer everyone to this New England Journal paper that just came out on paraganglioma and pheochromocytoma because it talks extensively about the importance of genetic workup. Do you have a post on the patient? An autopsy? I'm sorry.
No, we don't.
You don't, okay. I might think, after being concerned about an extra-adrenal paraganglioma, but with the catecholamines normal, I feel comfortable that's not the case. So with his chronic pain and his presentation, when you first presented him, he had what sounded like trigger points and a number of other things. Could he actually have a pseudo-pheochromocytoma post-pheochromocytoma removal? Because I have followed patients with pseudo-pheochromocytoma. Nobody wants to take care of them. They shouldn't be on narcotics. They need help. They need understanding. They need reassurance, but they don't need certain things. And this guy was on this patient, was on a very unusual hypertensive regimen that was fortunate for him initially. He was on no volume reduction therapy, volume retentive therapy, an alpha blocker, a homeopathic dose of a beta blocker, and diltiazem. And he was fortunate in that regard. But I would have loved to have seen, before he passed, a 24-hour ambulatory blood pressure, because these people tend to have in-office hypertension, and they don't have out-of-office hypertension, and you can really reassure them. So I would think the most likely, without an autopsy, which is sad, I would be concerned that he actually has a pseudo-pheochromocytoma after a pheochromocytoma was removed.
Okay, so that's very, very interesting. We have a limited amount of time, so the last few comments need to be very brief because we're eating into the time for the next case.
I'll agree with Dr. Carey and many of Dr. Basil's comments. I wonder also about drug contributions to his hypertension. So this didn't resolve. He clearly had biochemical resolution. And I was wondering before the pheo if baclofen could be contributing to the blood pressure lability. And the fact that he used opioids and maybe avoided baclofen at times when his blood pressure was controlled may support that. And there's certainly hypertension if you have baclofen pump malfunction and high doses. So I wonder if baclofen or some other drug could have been contributing to it.
Okay, we have next comment and then you'll deal with them all together.
Sorry, just a quick question. Thank you for the very interesting case. I was just wondering, in this diabetic patient, I know he had a normal creatinine in 2014, but I didn't see any urine tests to see if he had any glomerular disease, urine protein, urinalysis, just to make sure he didn't have any hematuria or proteinuria that could be contributing to his hypertension or a sequelae of his hypertension. So.
He did not,
Yeah.
actually. It
Okay.
was part of the 24 urine testing, which I didn't put in here.
Okay, we keep it brief.
Okay. I noticed in the urine tox that there were no opioids, despite hydrocodone being on his medication list. And I wonder if he might not. I noticed that post-pheochromocytoma resection, he was still hypertensive, but not as hypertensive. And I wonder if he might have opioid-induced hyperalgesia, complicating his post-op course, causing the more moderate elevations in blood pressure with a once-daily dosing of hydrocodone, which maybe he wasn't even taking every day based on the urine tox.
This is kind of a rhetorical question, but there is something that hasn't been answered to me in this case, probably because you didn't ask the surgeon. I have seen patients with pheochromocytomas, this huge one, I have to confess, among 15 or 20 that I have seen in my career. But this patient had a symptom that cannot be neglected, which is he had the paroxysms on a certain position only. That indicates to me that there was an anatomical structure that acting on the tumor like the hand of an observer who examines a patient or the manipulation by the surgeon. It was some anatomical structure that compressed the tumor in a certain position. Did the surgeon have any idea of that?
He had, because I talked to the surgeon before the patient actually had the surgery and explained the labs we saw. These 50,000 total metanephrines actually we got those because the patient bended to the right when he had the blood work done. Because he wanted to make sure that his labs are really high when we take the labs. And so he said he squeezed a little bit to the right.
It's very interesting because you can compress a tumor, you can compress the renal artery with the mesenteric ligament, and like Dr. Iga mentioned, you can also compress the vertebral artery in a guy who obviously has cervical spine osteoarthritis, right? Then those are the positional hypertensions.
And the patient knew about it, basically, and was helping us a little.
That's great.
Just
last question
just
from
one
my co-chair.
question or comment. It's really interesting, and I'd like to know your thoughts. This patient had this sort of chronic history and these episodic events with very severe hypertension, yet he had no evidence of any target organ damage. Is that correct?
That's correct. And the echo we did pre-surgery, no LVH, which is normal echo.
Which is amazing.
It is.
Which is amazing. And then the demise, presumably due to cardiac complications, we assume sudden cardiac death, arrhythmia, we don't know, without obvious structural changes in the heart. So fabulous case. We're very grateful to you. I think in the paper, we might want also to discuss a little, we don't have the time, the perioperative management, because I worried a little that there was some huge blood pressure rise because of this huge tumor the moment the surgeon touched. And the issue for me is, was he alpha blocked enough? Because I've seen a few such huge PHEOs, and we tended to alpha block until the patient couldn't stand, because we worried so much about unstable blood pressure during surgery. And I just wonder if that contributed to complications. Don't know.
So just a quick comment. I was equally concerned about using doxazosin alone in a patient like this.
Yeah.
So we would use the general alpha blocker, and we would probably combine that with metyrosine to block catecholamine secretion. So a double blockade would reduce, at least be predicted to reduce perioperative complications.
I agree, and we'll try to cover this in the paper between us.
Yeah, so phenoxybenzamine plus or minus metyrosine.
Right, that's great. Thank you very, very much.
Thank you.
Fantastic case.